Hello, this is Andy Giz, and it's September 23rd. We're going to do a really big update today on the Omicron bivalent vaccine and a lot of information on long COVID. And I will share on YouTube a PDF of all the resources. So the quick, the good, the bad, and the ugly. So on the good, we have the bivalent vaccines have arrived, both Pfizer and Moderna. We're going to discuss when you should take it, which one you should take it, and you also take it with the influenza flu vaccine. We are going to talk about the bad, which is we have, of course, new variants emerging. Hybrid immunity is only providing 15% protection against BA5, so you need to get the BA5 Omicron vaccine. Wastewater seems to be showing an increased level of infection with BA5. And we're going to take a deep dive on people who have two types of complication. One, they have complication after the acute infection, cardiac, neuro, and stroke. And people, unfortunately, start developing long COVID. And we're going to do a lot of information update on the latest on diagnostic and treatment with a lot of PDF links. So please, if you know anybody with long COVID, give them access to this YouTube video and to the link I will post to download the PDF. And then we're going to see the true pandemic death toll has been estimated now at 22 million people globally. So let's take a quick dive. Just a disclosure that I'm not a doctor and I'm just taking published information from reliable sources and help you digest so you can make better informed decision. So, variant, BA5 is still dominant, but you can see it starts slowing down. And we have this BA46 that's starting to rise, including a whole alphabet soup of other diseases, including some of concern, which is 2.75 and 7. So let's take a look at the lineage for people who love the biology part. BA2 is kind of the one that started creating all these variants. BA5 has been the dominant one this summer. And it's creating all this alphabet soup of variant, and some of the old BA2 is also emerging there. So let's take a quick look at the one we worry about. You can see we are mapping the growth rate, and that's when you start seeing this 2.75 and the BQ1 that's getting to emerge at a faster rate, but still BA5 is the dominant variant. So 275 is a concern because it escaped the antibody from prior infection. We heard this before. And so there's a concern that if it becomes dominant, which is not the case, I want to emphasize that BA5 is still a dominant one, that could have an impact on the immunity of the country. So which vaccine should you take? So Pfizer has been approved for over 12 years old and Moderna for over 18 years old, but they just submitted yesterday to extend their vaccine, the Omicron vaccine, to 12 and up. So I just want to reemphasize there's no human study yet, but it was approved the same way we approved the flu vaccine based on safety data and the fact that the process that we developed in the past is the same. There's a lot of studies showing you can mix and match between both vaccine. In my cases, there is a shortage of the Moderna vaccine because of FDA has put some challenges on some of the manufacturing processes, so they have a backlog. So I took the Pfizer this week. So the big thing to remember is that it's really the reason you should take is to decrease the risk of long COVID by up to 50%. And we're going to spend quite a bit of time in this update about the real risk of these diseases is long COVID. So when should you take it? This is important. At least 2 months after you've completed the initial 2-step vaccine of the initial series or the one J&J one. If you have been infected, the CDC recommends you wait 3 months. Otherwise, you don't get the same strong immune response because your antibody attack the vaccine. You don't really have that boost in antibodies. If you're pregnant, the CDC recommends taking the Omicron vaccine. And if you have not had any booster, you should also take it. Younger people, it decreases the risk of long COVID, so please take the Omicron vaccine. You are the highest risk with long COVID. And a lot of people are asking me, well, should I wait for the next surge? Remember, it takes 2 to 3 weeks to really build the antibodies, and some of these surges have been really fast. So you don't want to wait until we find out we have a surge, because by that time, you may be at risk of getting infected. There is no Omicron booster approved for the kids below 12. It's expected that maybe later on in a couple of months, there'll be a submission to FDA. So Moderna seems to be slightly better than Pfizer's. The data continues to show that there's a small superiority there. But if Moderna is not available, which is the case right now where I am, please take Pfizer because the difference is not that significant that you should wait and be at risk. So hybrid immunity. So how do we, everybody is like 2 dose, 3 dose, 4 dose, hybrid infected. It's really getting to be difficult to do those studies there. But at a high level there, people who have hybrid vaccination only have 15% protection against infection. Not severity, but infection there. And that's the equivalent of people who only have the 3 doses, the 2 original dose plus 1 booster. And so the data seems to be really showing that to really protect yourself better against infection, you really need these 4 doses or this new Omicron. So again, I'd like to reemphasize that hybrid immunity does not necessarily protect you against getting reinfected with some of these new Omicron mutations there. So, do you take it with the flu vaccine? Well, the CDC just wants to encourage people to get vaccinated, period. So they're pushing people to take both vaccines at the same time. I did not personally, and the reason, when you look at the data, the timing of the influenza season is really from December to all the way to March. And the problem with the traditional flu vaccine is that the best time to take them is late October to November. And the reason is that they literally degrade 10% per month. So they only offer you 4 months of solid protection. And this is an example of a study showing that the degradation varies by age and the type of vaccines you have, but it's roughly around 10%. So what you want to do, if you can, is to probably wait until late October, early November to get the flu shot. BA5 positivity index is still, depending on the sources, between 10%, which is the CDC, to 27%, which is Walgreens. And you can see we've had a little bit of a rise, especially in the Northeast. We're going to talk about that. And this is an interesting graphic from Walgreens that showed that the positivity rate is linked and correlated with how long you have had your last dose. So if you had your last dose in less than 3 months, you have a lower percent of the population gets infected than the people who have had no booster for the last, 6 to 12 months. So quite interesting. And wastewater is always an early indicator of a rise coming. You can see that when we had the Omicron, it was several weeks ahead of the cases being diagnosed. We're having a rise, not as bad as what we had for the last Omicron, but I want you to be aware there's a rise of the wastewater across the country. And the Northeast is leading the charge. And it's clearly, as the weather is getting colder there, you can see that there is a rise in the wastewater, which means it's probably going to be a rise of cases in the Northeast. California, we still have nice weather there. So you can see in Palo Alto, for example, we're having a decrease over the last several weeks there. So we look good. So another warning is the Omicron is not maybe as accurate when you're testing the traditional antigen test that you have at home. Because remember, these tests were developed for the original Wuhan. So I just want to give you the heads up that the accuracy has dropped from 87% for the FlowFX to 81%, but for clinic tests, which a lot of people have, from 83% to 70%, which means retest yourself, 1 or 2 days apart, especially if you have any type of symptoms. So just be aware of it. So there's been in the news the fact that people with ApoE4, one ApoE4, may be at higher risk of having worse COVID outcome. And I want to really clarify that because it turns out that it's only for people who have both genes mutated, and that's only 2 to 3% of the population. Around 20 to 25% of the population has one ApoE4. So I just want to reassure people there that it's for the rare people who have these 2 to 3% there with both mutation. You may be familiar with ApoE4. It's the mutation that people are at risk for Alzheimer's. It's also higher risk for atherosclerosis and anti-tumor immunity there. And you can see in the graphic there that E3 is kind of the reference, the green line there, and E3, E4 is pretty much on the same trajectory. It's the people who have the dual mutation, which is E4, E4, as well as the rare people who have E2, E2, which is protective for Alzheimer's, but seems to not be as protective for the case of COVID there. And I just want to show you the data there. This is the baseline, the dotted line of 1, and you can see it's only the E2, E2, and E4, E4 that are higher risk there. And then to keep perspective there, the risk is only, twice the risk, where, the man versus female is also twice the risk. So it's not a huge significant risk. So I don't think you have to worry too much about it. That's my personal view. Impact on body aging. Another good reason why you should take the vaccine is that a vaccine reverses your aging process by 4 years if you're over the age of 50. So I'll take that. And it also makes the case milder. And so if on the other hand you have COVID, unfortunately COVID it seems to be decreasing your epigenetic age by at least 2 years. So again, I know that some people just think that, hey, we're just all going to get it, let's give up. Don't do that because this vaccine have a lot of positive help on your overall health. So I want to talk about two things. COVID is making people sicker two ways. One, immediately after the acute infection, we're going to talk about that, and the other one after 2 to 3 months, they develop what's called long COVID. So I'm going to separate both of them. So what more and more data have come out recently there show people that have had an acute infection of COVID are sicker immediately after they've had COVID there. And it's being monitored by increased stroke and heart diseases and heart attacks and heart failures and arrhythmias and the whole shebang. And pretty much you should expect that if you do get infected with COVID, you're going to get a higher cardiac risk. So if you have any pre-existing condition, you should really a little bit be more cautious after you get infected. So to give you some numbers, the Veteran Administration did a study estimating that in their population there, they had an extra 12,000 extra strokes in 2020 and 44,000 extra heart attacks. So this is before some of the vaccines were available. And in 2021, you can see there's still more stroke and heart attack because we had a higher volume of infection with Omicron. The mechanism is the virus spike protein bind with the human ACE2 receptors there, and unfortunately these are the ones that do this blood clot that create all this cardiac risk there. So we still have those issues there. Another VA study showed that it's basically this whole inflammatory heart disease cascade is really for people who at the highest risk is people who are in the ICU. People are hospitalized, but also people who had mild cases that were not hospitalized. So just because you had mild case doesn't mean you don't have any cardiac risk. So just keep an eye on any symptoms and go see a doctor. The other surprise is that we have discovered that the COVID enters our body through the nasal pathway, and unfortunately, the blood olfactory barrier does not stop the virus to get into the brain, which is why we're seeing all those people having neurological problems after the infection. And what we have discovered is that the olfactory epithelium, which is the barrier there, somehow does not allow the antibodies that we build from our vaccines to basically get into that lining there, and so that the COVID has an easy pass into the brain. And that's really bad news because we're now documenting more and more of this cascade brain inflammation, which unfortunately create a leak in the blood-brain barrier. And it also infects the astrocytes. And the astrocytes are important there because they are the glue that hold the brains together. And these are the ones that basically nourish the environment. It's like the food supply of the neurons are being compromised. And we also see abnormal PET scans, which are the scans of the brain that show the functionality of the brain in multiple areas of the brain that affect all the area that people have symptoms, which is smell, memory, cognitive abilities, chronic pain, and sleep disorders. It's affecting younger patients between 20 to 50 years old who have never been hospitalized there. This is a study from Dr. Wes Elling. Another study by the Lancet on 2.5 million people were being matched. You can see this cascade of brain injury is showing up with a lot of long list of symptoms there, from Guillain-Barré syndrome to epilepsy. I just talked to a woman who had long COVID that had these seizures. So really be aware that, you know, there is a period after the infection there where the brain and the heart system are being attacked. And you really need to give yourself 4 to 8 weeks of recovery to help build your immune system to clear the virus. Because as I'm going to show you, the virus is basically embedding in your organs. So don't assume that the test of your nose turning negative is the end of the infection. It is not. You really need to help your immune system fight it. The other bad news is for people who over the age of 65, there's a 50 to 80% higher risk to develop Alzheimer's in the following year. Now, to keep the perspective, the risk is 0.35 going to 0.68% per year. But, you know, it's something that, again, confirms that the brain is getting injured by this COVID infection. So let's differentiate between the acute part, which is in red, which is more severe in male than female, and there's this whole pathway and symptoms I just described, and what's called long COVID, or PACS, and which is kind of interesting because it has a higher incidence in female than male, and it has slightly different symptoms and imaging diagnostics. So I want to really differentiate between the two groups there. What we believe more and more is that one of the key causes of the long COVID long-term damage is the inflammation of the endothelium. Again, the endothelium is this barrier that helps block, and we've just seen that the endothelium of the lining of the nose doesn't stop. It doesn't load up with antibodies, so the COVID can get through to the brain. And also the endothelium is everywhere in every blood vessels, and of course that's why it propagates to pretty much every organ in the body, creating some of the damage. So we estimate in the US between 8 to 22 million people suffer from long COVID. This is a CDC estimate. It provides higher risk, and we're going to talk a little bit about what are the different issues. One of them is an increase in type 2 diabetes. So if you're pre-diabetic or obese there, really keep an eye on that. So I'm not going to go into all the details. We've talked a lot in the past there, but you can see the many effects of long COVID. But I want to distinguish between the young and the older population there. The people seems to have some of the bigger problem there are the younger population there who had mild acute infection at the time. And you can see it's across the board. It's these are the risk factors. So one is the normal compared to a healthy person there, and this is 2x there. You can see a lot of them 1.5 to 2x, especially in cardiovascular, pulmonary. Again, acute pulmonary embolism is when you have a blockage from a blood clot or air that goes into the lungs and you're having problem transferring oxygen. Renal failures, all the vascular system there, neurological, mental health, the brain fog we talked about. It's pretty much every organ in the body gets affected in long COVID there. We believe there's 4 reasons for it. One, I'll show you some pictures. There's this virus that basically penetrates every organ in the body, and it stays there and continues that inflammation response. And there's been autopsy up to 180 days showing it's still there. There is another pathway there that it may trigger autoimmune disorders. And so you have this cascade. And then you have people who had latent virus, i.e. virus that were dormant that get reactivated while the immune system is weak. And then we just talked about all these blood clots and lung fibrosis and all of that from the acute phase of the disease that start creating long-term problems there. So to give you, again, you go back to this endothelium, which is the lining of the cells that has an inflammation that start leaking. And that seems to be kind of the common pathway that create these 4 different problems there that we just described. To give you an idea, these are a disruption after infection there, where they put some body tissue there that were magnified at 500 times, and you can really see in the red the little COVID RNA that is still present pretty much everywhere in the body there. Now, to be fair, we don't know if these RNA are still active, like a virus, or these are inactive things, but it's tied to the symptoms. This is another picture of the small intestine, and you can see in this case it's in green, the virus that's in the lining of the duodenum, and and so creating a lot of intestinal problems. There was this young woman, 11 years old, who had a mild case of acute, and 3 months afterwards she started developing some of this chronic colonic inflammation there. They did an endoscopy and they took some tissue samples. And guess what? Again, you can see this case in the brownish color there. Unfortunately, the virus is present. So in the brain, same idea here, the microglia are being activated and they are basically creating these long brain inflammations there. You can see healthy versus a COVID patient there. You can see that increase in the brownish color there. And this is a white matter on top and the gray matter at the bottom there. This is all tied to the neurological problem we see, the brain fog, the memory recollection, all of that. It's like a massive concussion of the brain is the only way I can explain it. Another picture there to show this is real there. You can see in green again the virus spreading in different parts of the brain. So what does that mean? That people have these long-term problems there. There was a study by the VA, and to get perspective of that VA, it was done in 2021. So when people did not have, so before the Omicron big surge there, and only 1% of those young adults were vaccinated. But you can see that you had these huge hazard ratios, which is 1 is the normal, so it's multiple factors there. In the loss of taste, which is typical from the disease at 1 year. Still a loss of smell and taste was still missing for a lot of those people there. A lot of problem with Guillain-Barré syndrome, which is a neurological problem on the face, another part of the problem of the body there. So again, we cannot ignore. This is a serious problem. I'm just not going to go for all of them, but you can really see the delta that is going on across the board there between the people who were mild, hospitalized, and in the ICU. So long COVID, it's very important, and this is really important. If you have anybody that you know has long COVID, send them to this video. There's going to be a lot of information. The biggest thing to tell them, relapse after exercise is the characteristics of the long COVID as well as chronic fatigue syndrome there. The worst thing you can recommend somebody is to say, go exercise. You really need to have these very controlled rehab procedures there, because this patient literally crash after walking or basically doing some type of heavy accelerated heart rate type of exercise there. And what we believe is that there's a dysfunction in the circulatory system, so where the blood flow of oxygen is being impaired to go to the muscles and the tissue, which of course means this severe fatigue. And the reason why you don't want to aggravate that is because you continuously increase the inflammatory substance called a cytokine, and over time that can basically damage the mitochondria but from the lack of oxygen there. So these are not things to do. Don't help people push themselves. That is the worst thing advice you can give them. The other problem we believe is going on is that there's this chronic inflammation of pretty much the whole nervous system, and you have this small fiber neuropathy, and that it creates basically a damage of the fiber, and as a result of that we have what's called dysautonomia, which means the autonomic nervous system, which is the way your heart rate, your blood pressure, your breathing, digestion, which is supposed to be automatic, is no longer working correctly. And one of the big symptoms of long COVID is what's called POTS, which means that you sit, your heart rate, blood pressure is regulated, you go back up, and your autonomic nervous system is not controlling automatically, and these people have swings of heart rate and blood pressure, which are absolutely abnormal. I'm going to go quickly over some of this, but they're all going to be published in that PDF. There's a very good long COVID guide to primary care, so physicians, that I think a lot of the patients may benefit from. It's being published in the UK. I will post the link also on YouTube. In the UK, they did an analysis that 70% of their population has been infected by COVID by now. 2 million have developed long COVID, with over 19% still having symptoms after 2 years, because we're now starting to get that data there. And then the vaccine, the rate of long COVID is only 5% for people who have been vaccinated. Again, I reinforce, if there's one reason you want to be vaccinated with Omicron, is the long COVID, decreasing that risk of long COVID. I'm not going to go into all the details, but it basically gives you all the list of the type of tools the physician should be using, what are the type of symptoms they need to look for heart rate, symptoms after exertions there, chest pain, all these other things like that. A lot of the other symptoms in gastrointestinal, cardiovascular, and then they make some recommendation on how to do the diagnosis. So this is kind of blown up in higher level there. You can see, you need to see somebody who has been trained in diagnosing long COVID. Not every PCP is up to speed on this. I highly recommend that anybody with long COVID, or if you're a caregiver or friend of a long COVID, you pass them this diagram, because I think it's extremely helpful to understand the diversity of symptoms. Good news, we had starting to repurpose some of the existing drugs to see if they could help. So for example, if people have brain MRI abnormality, we're starting to use steroids and IVIG type of therapy there. If people have any type of blood clots, we're taking a lot of anticoagulants. If people have air trapping along CT, which is the risk for pulmonary embolism, they use steroids. If we try to get rid of the virus that may be latent there, we're using a vaccination, remdesivir. I mean, so honestly, we are trying on people and see what works and what doesn't work. There's not enough data yet to basically have a silver lining that fixes everything. So just be aware there. So it's a combination of steroids and all of that to basically try to stop that cascade that I just described earlier. There are some leads that people are investigating to basically fix the immune dysregulation there, and try to help the blood vessel inflammation to stop and stop the blood clots to be generated. We try to basically flush the virus out of body tissue. Again, if you learn anything from this video, if you got an acute case of COVID, give yourself 4 to 8 weeks to fully recover there, so you don't develop long COVID there. So your immune system has a way to flush this virus that's everywhere in the body. If it's no longer in your nose, don't assume it's no longer in your body. And then we tried, using anti-clotting, triple therapy, antiplatelets, famotidine, against infection there. So we really try to find a doctor who has some expertise and is keeping track, because right now we're just experimenting, to be fair. Pretty much the UK is on top of publishing the data there. They do different treatment for 3 months, and then they report the outcome. Now, we try to find ways to do better diagnostics, because as you know, except for cardiovascular cardiomyopathy, which 10% long COVID patients have, the other ones, we don't really have good diagnostic and imaging. So a couple of interesting things have come up. We have discovered that people who have long COVID, so a healthy patient there is the person that has a cortisol around 100 here, if you can see that, get that kind of color, that peach color. And then the long COVID is more like the pink purple there. And you can see there's a big difference in the cortisol level of people with long COVID there. So that could be one of the marker that we may be helped to identify. We also starting to see some dysfunction in the hypothalamic pituitary adrenal axis there. And again, there's some type of test that can be done for there. But pretty much we have noted in the past that people who develop chronic fatigue syndrome, those patients also have low cortisol. So we started trying to identify biomarkers that could help us in diagnosis. The other thing that has come up is that why people having higher risk after 50, and we discovered that people over the age of 50 have a different T cell diversity. So the TCR basically is different in over P50 there. So again, we're trying to go into what are the population at risk, and is there a way to identify people. I'm going to basically put a PDF that shows some of the link on the latest long COVID research. The government finally, on August the 3rd, so it's not that long ago, appointed a National Research Action Plan on long COVID that's headed by Admiral Rachel Levine. They finally recognize it's a multifaceted disease that can affect pretty much every organ system and has multiple chronic health problems there. So the NIH received $1 billion for an initiative called Recover, but honestly, it's like slow as molasses. They were supposed to recruit 30,000 patients there. They're barely at 20% enrollment there. They have not really started any clinical trials for treatment there. Honestly, it's research, and they just observe. So extremely disappointed, but not surprised. I predicted that. There is another initiative called that's organized by the American Academy of Physical Medicine and Rehab. They are the one who manage a lot of these long COVID centers in the US. They have 46 months waiting list, but they're starting to issue some of their recommendation, especially rehab technique for people with chronic fatigue and shortness of breath. And what's the best way to conserve your energy and slowly rebuild your resilience there. So I'm going to put some of those links. So on the research update, there's a new initiative that just came up. That's a privately funded initiative there by Patrick Su-Xiang and other donors there. And the idea is to really start be much more aggressive in experimenting in different treatment, publishing the data much faster there, doing autopsy and biopsy, do all the things that the private startups, do much better there, which is what causes us and how do we get rid of it. We believe 8% of the US population has long COVID. It's expected that 1 million people out of the workforce because of long COVID. The Brookings Institute think it could be as high as 2 to 4 million people. So HHS has just come up with a report. Again, this is the link there on what are the different symptoms and how we define long COVID there. I'm going to post all those links there, which is a lot of self-help guide. You can buy a book on Amazon written by a specialist. The World Health Organization is also publishing a lot of links on rehab. There's a COVID recovery. The England, I think, is ahead of us in a lot of their guidance on how to address certain type of symptoms like dizziness or physiotherapy for breathing pattern disorders there. So I'm going to post these long COVID support groups. These are, again, more guidelines for the physicians' populations there on how to basically diagnose and treat those patients. And again, I'm going to post all those links there, which are a recommendation for all the different symptoms there. So again, if you know anybody has long COVID, give them access to this video and to the PDF. So US, as we all know, has been terrible on the normalized population there in their mortality rate. We mismanaged this, I think it's no surprise to anybody. The highest risk were people who are vaccinated, so I don't know how we can convince anybody who isn't vaccinated by now, but if you know anybody in your family, show them some of the data. It's still deadly for over 65. You can see a bit of an upswing there. It's the majority of the mortality there is 85%. People over the age of 65 with a bit of an uptick there, so we need to keep an eye on that. Worldwide, the Economist did a very interesting analysis showing that the true death toll is not 6 million, but 22 million globally, and the biggest underrepresentation in the official numbers is from Asia and China and India, of course. So I really appreciate your help. Please, this is a work of love. I don't get a dime from YouTube, even if they put advertising. They collect the data, they collect the money, I don't. So please spread this to your social media. I really appreciate your help. I hope this is the last one, but I said that before, so I may come back in 1 or 2 months if there is a lot of new information. Stay healthy, get Omicron vaccine, and enjoy the end of the summer.